great to have you. And I think you were on a number of years ago, and you've of course given 40 years of your life to actually focusing on treating cancer from back in after your short trip in Australia down under, return to the UK. 1984. Your name is also known for major advances and contributions to the HIV AIDS conversation and research. So there's a lot there within those 40 years. But maybe ask you a little bit about your career. Start with that, just to touch on that. I've kind of given some of the bullet points, but 40 years looking at this one issue tells me a little bit about, and maybe how things have progressed in your time, or what you have learned, the changes of approach to dealing with cancer. So yeah, fill us in a little bit around that.
Well, that's very interesting to ask that, because I just suddenly remembered my first indications why I thought I would do oncology. I was a senior student on a ward round with a surgeon, and they'd done a big operating list the day before, and it was the old Florence style ward. So we all went as a team, the consultant, the registrars, the houseman, and then there was me, the attached medical student. And we went round everybody and he chatted to everybody. He said, you had an appendix, you had a gallbladder, everything. And he deliberately missed out 4 people who were sitting up there really alarmed that they hadn't been told what had happened. And when I asked the registrar why he had missed them out and not spoken to them, he said it's because he found they had cancer, and there's no point doing anything, talking to them, because nothing can be done about it. So I thought, well, there's clearly an unmet need here. That was the first time I thought perhaps I would start looking at these cancer patients seriously. And I must say that I got very interested in viruses and cancer from a very early stage. And that's what drove me into the immunology of cancer, because when you mentioned the HIV, I worked out, and this is all relevant to what's happened with COVID, but we didn't get any kind of backing for this, that the pathogenesis, i.e. how HIV causes AIDS, was that it induces a hyperreactive immune system in people with the right genetic background. And I realized that you could usurp this type of approach to treat cancers. And it has been done in leukemias, lymphomas, without realizing the role that HIV played in this. And that's really that completely changed my approach. So my training involved, obviously, more the merrier chemotherapy. And I found that the toxicity relative to the benefit very difficult. It had to be an art form, because the response rates were so low when I started out in the late 70s doing this. But now they've improved dramatically. So we feel an awful lot of what we've done is worth it. And it's over 25 years ago, nearly 30 years ago, that I started doing immunotherapy for cancer. And for a long time, I was the only one. And they regarded me as a sort of a maverick trying these things. The patients were grateful because they had nothing else. And some of them responded dramatically. And that's what kept me going. So that's how I got into cancer. And I think I was the first to use high-dose interleukin-2, which was an American innovation, which was very toxic. And I found out the low doses were just as good if you used them in the right way without the side effects. And then I was one of the first to use cancer vaccines, which I started out with Donald Morton from the John Wayne Cancer Institute. And we were the only center outside the US working with him for a long time. And then I ended up examining trials with at least a dozen vaccines, and found that the very best wasn't really a vaccine, it was an immune stimulator. So this is how, that's a brief evolution of how I end up doing oncology, much different from how they would like to train me.
Well, there are a whole lot of areas I'd like to pick up on a number of things you said. But if I may jump to people watching today, just to look at how you engage with people who get that news, and then we can step back and look at some of the different treatments and the conversation about vaccines and all of that.
Mm,
But we're told that 1 in 2 people will get cancer. And I guess whenever someone hears they've got it, they feel their world has fallen apart.
mm,
They feel it's all over.
mm,
It's the panic sets in when you hear you've got the big C,
mm,
and that's it. How do you initially, I guess, engage with someone who has just received that? Initially, it feels like it's devastating news. It may not be devastating because how cancer is treated has moved ahead so much in the last few decades. But how do you initially respond? Because I guess the people watching, 1 and 2 of the viewers now, of the listeners, they will also be in that situation if that statistic is true.
Well, these days, the majority of people I see have already been told the diagnosis and often had appropriate treatment, and they want some more because the treatment tends not to be completely effective, and want to know what helps. So that's what I do. I really already have a patient who's gone through that process. When I used to see them more regularly in the NHS hospital, I'd be dealing with melanoma, stage 3 or stage 4, and they had already been told in detail the implications with all the leaflets and everything they give. Stage 3, which means you've got lymph nodes from the melanoma, is a very straightforward process, and if the management's done well, you can be sure. I saw somebody who I treated 20 years ago, only last week, who essentially had stage 4 because he had lymph nodes everywhere. He had a vaccine immunotherapy program. This is years before it was ever considered to be part of the protocol. Been disease free for over 20 years. So I have a lot of patients like that. And because I've been confident in them, I know the people you can be confident, because there's no point being a total pessimist and losing all hope, because it'll become a self-fulfilling prophecy. You want people who I'm going to fight this, I'm going to be positive and do all the other things to help. That's been my role, is this is what you have to do. We can only do so much. And a good example is that we found that when we did the early immunotherapy programs, this immune stimulant, and this had low dose interleukin 2, etc., we found that some people responded fantastically to this, but the majority didn't. So we spent that. The question is why? Why did this patient do so well and this patient not? So I was able to get out. I mean, I had all my research in this field covered by the Institute of Cancer Vaccines Immunotherapy, which is a charity set up to support me because the CRUK refused to do it. And yet another time when I believe the CRUK get everything wrong. So I'm just pointing out I couldn't have done this if it wasn't for the other charity. So I think people need to think very carefully what charities they support. The big ones, I believe, are just too much like Big Pharma. Any rate, I won't go into that, but because of this, we looked at all sorts of things, and the answer was so unbelievably simple. It occurred when they rolled out really reliable assays you could do quite quickly for vitamin D. And there it was. The only people who responded had good levels of vitamin D. The majority who didn't had low vitamin D. So we began correcting the vitamin D and our response rate went up. I mean, it's these simple things. I went to NICE with senior colleagues. It's well over 15 years ago, possibly more, with all this evidence to say that they should make it absolutely mandatory that everybody gets the vitamin D checked and it's brought up to high levels before you start treating. Because if it's low, you will not respond to chemotherapy. I mean, my colleague Daniel von Hoff, big pancreatic cancer trialist in America, I mean, he kind of laughed at me when I poked this out, and then phoned me up 3 months later, and he said, I've been through our records. He said, nobody responds to chemo in pancreatic cancer if their vitamin D is low. He says, it's unbelievable. So we're now correcting it, and we told NICE this, the most inappropriately named organisation since SAGE, and there are many others. But I mean, they might as well talk to keepers at the zoo, really, is all they're interested in. And they said, "Oh, we'll put it on our 5-year plan." Well, that 15 years have passed, and it's there only as advice for nutrition. It is vital for your immune response. And this is what annoys me. All the people at the top of these organizations are, to me, are idiots. They do not think of what happens in the interface between the patient and the clinician. They're too high up there in the clouds and elite. They think it's not important enough. They will get involved if Pfizer or somebody comes along with a new drug that costs 100 grand a year and is very toxic and works just in a few people, then they get very excited. But if there's something that's really cheap, non-toxic, has a mega effect. And I would have thought that was part of the NHS's role. And they clearly don't take their job seriously. I will levy that. I think to have all these patients come to me who fail various chemotherapies and things, and no one's taken their vitamin D level. I take it and it's in the boots. And I said, you shouldn't be allowed to start out on a course of therapy, chemotherapy, immunotherapy, unless you've had your vitamin D corrected. The data is that black and white.
Well, we actually got our first strike by talking about vitamin D during COVID, recommending or saying the research seemed to be that vitamin D was important in combating that, and we got a strike from YouTube for that. That was medical misinformation.
Oh yes. Well, we now know that Pfizer in the COVID this is before the vaccine. Basically, we're funding charities to put the correct information out there that vitamin D will only do you harm and has serious side effects. Do not take it for COVID. They were doing that. Why were they doing that? Because basically, with vitamin D and ivermectin, you'd have cured everybody that was curable. There's no need for the vaccine. That's why they did that. They were setting everything up. That's why in this country, Whitty and Vallance all changed their minds. And suddenly we're all for the vaccine when they had previously said some sensible things before. So the bullying power, and I mean, you have to basically remember that these big organizations, Pfizer has paid out billions in fines for withholding safety data, presenting the wrong data, bribing clinicians, bribing the regulators. This time it's a full house, bribed all the politicians and organizations as well.
Tell me, because when people get that diagnosis, they think, well, I'm going to go and be blasted with radiation, and it's kind of, will my body survive that, or will the cancer survive this? Kind of, which one comes up? It's when you look into chemotherapy and how it works, it seems a very destructive process, and that seems to have been, from my understanding, as I read about it in the general press, that seems to be the usual way of treating it, especially in the UK. Is that correct or not? Or are there other methods that are also used, or is that the normal route that people go down?
You're referring specifically to radiotherapy?
Yeah.
Well, with radiotherapy I trained as a radiotherapist for a year. I was thinking of doing that till I realized that actually radiotherapy was rapidly becoming a technical approach to cancer as opposed to an art form. I like the sort of art science aspect because we were getting to the stage when I did that time when people had the brilliant idea of linking the CT scans up to the radiotherapy machines so that they could actually treat the tumor in real time. And that led to focus radiotherapy. So radiotherapy was used in the old days, as we called it, spot welding or frying, which is one way of looking at it. So, and the other thing is that there's very high doses focused and not so high doses not focused. That's the so-called frying bit. a lot of the damage was in the frying. But with those computers and all the programs, you can now program highly selective stereotactic radiotherapy just to target the tumor. I mean, a very good example is prostate cancer, is that the selective radiotherapy with the right treatment has just as good as outcome as surgery. And that, and probably less side effects. I mean, that's the radiotherapists have claimed, and from my point of view, that is a very good example of where radiotherapy is probably a better option, because it has improved so much. And then other uses of it. It's and people forget this, because I remember I did a lot of radiotherapy for this. We didn't do it to cure the cancer. We did it to shrink the cancer, to reduce symptoms, pain, severe discomfort, etc. And it was good for that. So I think it's important people understand that radiotherapy is technically so good now that and the precautions taken to prevent the side effects are so much better that I have no big issues with radiotherapy. I recommend it for quite a few of my patients. If we have immunotherapy for a while with a lot of disease, and most of it goes away, and you have what I call a rogue elephant of disease, a lymph node that won't go down, then you can zap that with radiotherapy and get rid of it. And then you can actually render the patient disease-free. So these treatments need to be integrated in the whole of eliminating the disease, or certainly keeping it under control.
When you say integrated, is one of the issues maybe that we have in the medical profession is the specialty route, and it doesn't look, this my perception anyway, if you tell me I'm wrong, but it doesn't look generally at the holistic side of the body, and certainly doesn't bring into account other factors outside the body like diet or food, or it focuses so narrowly on an area. Is that part of the reason maybe why these are not being tackled properly, because we're too narrow focused and doesn't connect with other fields within that? Does that kind of make sense?
Well, certainly what you're ringing bells. It'd be what I'm hearing from a lot of people is certainly the medical training has been much reduced. It's very, very truncated compared to my day. And people are specializing far too soon in just their particular areas. And so they're not aware of the bigger picture so much. So they will just say do radiotherapy of just the chest, for instance, or etc. Or they will just do surgery on one bit, which is probably a good thing because they get very, very good at that. But because of this, there seems to be a failure to stand back and recognize all the other things that might be contributing to the issue. So the good generalist physician, I mean, that seems to be lost now. Everybody is a specialist of some sort, and you can get through to that position much quicker than in my day. I mean, when we did oncology, we were expected to have done quite a few years of really high class internal medicine, we called it. So you did everything. You did the infections, the autoimmunities, and the cancers was one of them. And then we started branching out and said, we can't do all this, it's too much work, we'll just focus on the cancer aspect. But now it's cancer of that, this, and they don't see the whole big picture, which is why I believe simple things like vitamin D was missed, and why the importance of the diet and exercise, for instance. I mean, my own colleagues dismissed all this of complete waste of time messing around with these issues. They have nothing to do with it. I mean, I was told that by colleagues at very well-known cancer hospitals and totally dismiss it. No, I mean, it is, people accept that in order to have a good outcome, you do need to address the diet, lifestyle, stop smoking, stop doing several other things that we know are bad, reduce obesity, and all these things need to be done. And one of the things that came out recently, which I was really very interested in, it was a study showing that exercise really improves the outcome of colorectal cancer. Now, that's fascinating because I remember being in a big meeting on tumor immunology. It was over 10 years ago, and a fellow presented a mouse experiment where they had mice with the tumors, and the mice, the poor fellows, had to do this compulsory exercise on a wheel, the way they run around on the wheel. And they split these mice into that. And he was very excited. He said, the mice who have to do this, their tumor is much slower to progress than those that just sit around in the cage eating. So he'd actually established, and then years later, we found out that this is working in the clinic. Now, the whole time of the training I did, nobody ever. I mean, now there's a lot of people with different inputs in clinics. You're getting dietitians and you're getting physios for all these sort of things, which is good. It's very good. But when we were trained, we were all trained that this is all nonsense. You just need to focus on the cancer and kill it. But now it's become clear that we need to take all these other things into consideration. And perhaps the most important thing is, you alluded to, it is the attitude. It's coping, right? That's what I've got. What can we do about it? What are we going to do about it? How can I improve the outcome? That's what we've got to capture now, as opposed to, oh, this is a disaster, etc., which is the natural reaction initially. But I must say that I'm quite proud of the cancer world, because we have improved the outcome of cancers dramatically since when I was even a registrar. And, the thing I'm most proud of, in spite of all the HIV and the vaccines and immunotherapy, was a period in my life when I was doing the general medicine bit. And I had this terrible woman with one of the most dreadful autoimmune diseases known, who was steroid resistant. And I had remembered that a similar case had been reported as a single case as responding to thalidomide, which was given to them to help them sleep, because that's what it was used for with pregnant women. Then they realized this disaster they were causing the birth defects. But I remembered it had this effect. So I gave it to this woman, and she had a fantastic recovery, having been reduced. She was like a skeleton because she couldn't eat or drink. She had mouth ulcers everywhere. It's just absolutely awful. And to see this woman recover within 48 hours after giving thalidomide made me shout and say, don't throw the baby away with the bathwater. And I tried to get backing to go into this. The Wellcome turned me down, the MRC turned me down, the CRUK, what it was then, to all turn me down on the grounds, don't we realize this drug causes severe side effects? We cannot possibly get involved with birth defects. I said, well, don't you realize that I'm an oncologist and every drug I use will cause birth defects if I'm stupid enough to give them to a pregnant woman? What bit do you not get? Well, fortunately, my fury was brought to the attention of some people who knew about thalidomide, working in a startup company in America. Anyway, the bottom line is, I said, I'd love to work with them on this, but thalidomide, I'm not worried about birth defects. I'm worried about if you use it for 2 months or more, you get very bad neuropathy. And I was showing you needed to keep giving it to get the benefit. So anyhow, I finally persuaded them. It took 2 years to make analogs. That means you take the thalidomide and you tweak it here and you screen. Long story short, any rate, out of this, we had a fantastic drug, ticked all the boxes. That drug's now called lenalidomide and is used worldwide and has been the most important drug in increasing the survival of multiple myeloma from 2 years to 7 years. And that is an incredible improvement. So going into cancer actually is very, very exciting. And I actually have some personal friends who are taking it as maintenance treatment. And that's a great feeling to think if it wasn't for my persistence, that drug wouldn't have been around. So it's so this is what you have to keep driving forward. There is a great thing if I don't do something and it's not going to get done, and that's what keeps people like me at my old age still flying the whip about trying to improve everything, because for the training at the moment it's far too specialized, and that means that the clinical trials have to be they're made to be big, and all the research is big pharma driven, which is why what I call the really obvious improvements are ignored, even though they're very clear, because they're not being pushed by a big pharma. And
that's what I was going to say is the drive, is the cancer industry, because everything becomes an industry looking for good outcomes and generating money to continue that. Is the drive from the pharmaceutical industry, or is it from doctors actually on the ground and what they're getting from patients? Is there a lot of crossover between those, or is it pharma do the research and then they're the ones that decide what to do? I mean, where is the focus or the push or the collaboration there?
I think it's nearly all industry driven.
Wow.
And one of the things I mentioned, we had this immune stimulant, which had made such a big improvement in melanoma. And I was finding that it was the case in many other ones, even pancreatic cancer. We did a randomized study which showed it did improve the outcome of pancreatic cancer. And when we tried to get CRUK to help us with this, because there was no big company, their attitude was kind of, well, if it's important, you'd have a big pharma behind. And then if you did, then we'll collaborate with them. And I said, you raise millions and millions and millions of pounds a year off poor, unsuspecting public with give us your money TV adverts, dreadful thing. And they're telling us you basically just exist to subsidize big pharma to make big profits. I mean, that's the way I interpreted this interaction.
Tell me, you touched on immunology. Tell us a little bit more about that, because my understanding is immunology is about the immune system, which is protecting the body from outside attacks, and cancer comes from within, from the cells within. So how does immunology fit into the conversation on cancer, or does it not really?
Well, it does completely. That's the other thing I was told by senior colleagues, that the immune system had absolutely nothing to do with cancer. For years and years and years, I was told this. And I started to get very suspicious of this over the years. HIV kind of confirmed it, because when the HIV wrecked the immune system, cancers popped up. Lymphoma, for instance, Kaposi's, CA cervix, they all came out when the immune system went down. But most importantly, and Gene Shearer, who I think is the best immunologist I've ever come across in the world, he's long since retired. Basically, we started looking at the immune response in people with cancer. And he did lymphomas and glioma. I did melanoma and colorectal. And the colorectals were just unbelievable, because we had very interested people at St. George's who wanted to do some research. And we found that if you have colorectal cancer and it's early, we could still detect really marked immune suppression. And the reason that this changed my approach to everything is when you removed it surgically, so there was no cancer left, and you measured the immune response, it would bounce up all by itself after it was removed. The only conclusion with that simple experiment is the cancer caused the immune suppression. Now, we could get over that by just cutting out the colon cancer. Now, I got interested in this because the majority of my melanoma patients, we couldn't cut all the cancer out. So that told me you had to boost the immune response that these tumours were suppressing before you were going to get anywhere, to get in a level field. And that's basically what we showed. And we improved the outcome dramatically by boosting the innate immune response. So the new immunotherapies are antibody-based, and they're not targeted, as people always start talking about targeting cancer. No, they're not. What they're doing is taking the brakes off the immune system that's been suppressed by the cancer, which is why in certain situations they can lead to complete responses. It was very good in melanoma. Lung, there's about 23 different cancer types respond to this type of immunotherapy now. And why? They have very bad side effects because there's no direction. They take the brakes off the immune responses that would attack you but are being normally controlled. We would love to have a mechanism whereby you could take the brakes off everything that would get rid of the cancer and not give you the side effects. I believe that's within the realms of possibility. And a couple of things that we're working on can reduce that sort of side effect profile. But that's the so that's the concept. With regards to what causes cancer, people always say, well, what causes cancer? Well, the first thing is having the wrong parents and grandparents, and your genetic hand of cards you get given. I mean, that's just one of those things. But then what causes it, and this is what I came out of my research into HIV. How does HIV cause this immune suppression? It never caused immune suppression unless you had immune genes that reacted to the virus in a non-specific way. So it was a big inflammatory way. And then we realized that when you have inflammation, you get automatic immune suppression and lots of growth factors which cancer can take advantage of. So I have written books and lots of chapters and co-edited books on the role of chronic inflammation in the development of cancer. And when you think of all the long-term ones, they're all associated with chronic inflammation. Everything from the mouth, esophagus, stomach is due to chronic inflammation from smoking and bad food. Everything that's in the lung, particularly, we know is a strong association with smoking and other bad inhaled things such as asbestos, etc. The asbestos is very interesting because the chronic inflammation, which you can tell if you happen to be looking at someone exposed to asbestos by chance, induces a very low-grade chronic inflammation that might take 40 years before you get the mesothelioma. Now, at the other end, the colon, for instance, a very common cancer, it's much more likely to arise in chronic inflammatory processes. And these include ulcerative colitis, I knew that as a medical student, Crohn's, and polyps. And polyps are basically an inflammatory lesion leading to an adenoma, and if you don't cut it out, it will go malignant. So if it wasn't for the chronic inflammation, this process wouldn't happen.
Tom, there have been a lot, I think, especially in the US, there's been a lot of talk about alternative ways of treating cancer. I don't know whether this has only been more recent because many of us are now plugged into alternatives during the COVID time when we were told one thing and that was it. Well, we looked for other alternatives. But certainly in the US, there's been a lot of talk on certainly ivermectin. That was kind of during the COVID time. But then also fembendazole and mebendazole. Those three have come up a lot as I've looked into this. How do you see that from a UK perspective? Are these drugs that are generic and therefore don't make money? Are they drugs that haven't been studied for this? What's your perspective on that and these type of drugs being discussed as options?
Well, my take in the UK, it's not taken seriously by oncology at the moment. Looking at ivermectin, I've looked at a lot of drugs. I mentioned thalidomide. We've looked at CBD, artemisinin, all these, and found that They all have anti-cancer activity of some sort. Ivermectin has many different anti-cancer mechanisms, and as such is a very good candidate to take through and explore. And again, people don't seem to want to do this. Remember, ivermectin is given to millions of people worldwide. One of the reviews I read suggested it saves 2 million people a year from blindness because it kills these plagues. The other drugs, which are similar but different, mebendazole and febendazole, they are also used for parasites and what have you, and they have crossover links. Now, I remember years ago, people from South America presenting that they could treat breast cancer and other cancers very successful using a concoction of these anti-parasitics. But what you're seeing now is people using these in cases where other conventional therapy is not working. And the responses, I must say at the moment, are anecdotal. The good thing is ivermectin has very, very few side effects, up to several times more than the normal recommended dose. Mebendazole, febendazole have a potential liver toxicity, so intermittent use is strongly recommended. A concoction using both of them is sort of widespread in people who are interested in extending out the efficacy of treatment of cancers, particularly those that we can treat but they come back all the time. And so what I think we need to do, these drugs do not carry the big profit margin. What I think we need to do, and this is the sort of thing NHS should be doing, and I hope like the NIH, etc., is doing studies on this. Is this real? We'll pay for the studies. Don't wait till the drug company comes along, and do the studies and see if there's something in it. My gut feeling is that there is benefit, but once again, it will be in some people probably quite marked, in other people you won't see it. So you need to get as much data in. Is it people respond? There's some responses to ivermectin which are quite dramatic, but it's the lack of lots of such reports means that these are every now and then. So you need to have a database of what exactly is it that when ivermectin really works? Is it a particular type of tumor? Is it after or with different types of treatment? And the other thing at the moment, we don't know the best management protocol or the best dose. So you have people using ivermectin, increasing the dose to really enormous level. The normal dose is like 12 milligrams repeated 1 week, and you can get rid of 99% of all known worms. In oncology, they're using 1 milligram per kilogram, which means instead of using 12, you'd be doing 70 to 140, whatever, every day. So these are incredibly high doses compared to what we use. And in my laboratory work, I've been really impressed that many drugs are actually much better used intermittently. And it's the withdrawal period you get the anti-cancer effect, not the constant exposure. So we need to put that into the trial, which we know it's a good anti-cancer agent because there's been a lot of work on it. We don't know how to use it properly, and that's what we need trials doing. Are we better off? I did a tour with Paul Marrick. We're both very interested in this. Are we better off using ivermectin intermittently at more normal doses and adding in mebendazole for bendazole, or increasing the dose continuously of the ivermectin? Now, I mean, I've met people who've done the latter, but still not really had anything you could call a response. So we're in a very grey area, but it needs formal studies that are conducted by clinical academics, which we've virtually been completely eliminated by Big Pharma will tell us what to do philosophy that the NHS seems to have adopted.
Yeah, because I've read certainly in the US that the cost of chemotherapy can be $100,000 and more. I don't know if that's per year or per dose. I don't know how it works cost here, but then I guess that means there's no incentive to do research on some of these more generic drugs that may come in at a fraction of that cost.
Well, that's right. I mean, majority of immunotherapy of the drugs that I've worked with, I'm horrified to find that patients go privately and they have to pay for it. They're costing 6-7 grand every 3 weeks. Now, the NHS doesn't get much of a discount on that. They say it's all confidential. But I do know a retired head of one of these major giant big pharma companies told me that he loved dealing with the NHS because they assumed that they were getting a very good deal because we're British. And he said it is so easy he didn't have to negotiate hardly at all. And that is one of the problems of the NHS. It is unbelievably incompetent and corrupt all the way through. And, people say, you can't say these things. And I said, well, I've just said them. If you look at the newspaper yesterday, you'd have seen 4 senior managers jailed for a massive part in the corruption of doing contracts for IT and things like that. And the word here that makes the big difference is this was only discovered through chance. Well, any big organization should have enough checks and controls, so this would be impossible. No, not with the NHS and many other government bodies, I'm afraid.
Can I finish off just with talking about vaccines? A lot of concerns, a lot of evidence seems to point at the rise of cancer, especially turbo cancer, linked to the COVID jab, especially the mRNA. And yet we're told we'll have a super duper mRNA cancer vaccine that will actually fix it all. Where does the truth lie in that? Is mRNA vaccine, is that the holy grail, or is that just fixing the problems that have initially been caused by the original vaccine?
Well, yeah, the latter is a good thing. But I can assure you, after doing several decades, the messenger RNA wants to target tumor antigens, and they're boasting they can plug it in and have a vaccine very quick. Now, I was head of the Institute Cancer Vaccines before it was merged into Institute Cancer Vaccines and Immunotherapy, and I took part in at least a dozen trials with the cancer vaccine. So we had MARCH, MART, NYESO. These were all going to be targeting these things would kill the tumor. No, just like chemo resistance, you target the tumor antigen, cancer antigen on a tumor cell with incoming missiles, the cancer is going to down regulate that thing. So it's within 3 months, it's not on the tumor, and the tumor's powering ahead. So, I mean, that is quite an incredible thing to do. I think it's going to have a very limited role, and I think we should not be using messenger RNA technology for this. And I can tell you that I have gone through and read at least 13 mechanisms whereby messenger RNA vaccines can induce or promote cancer. I mean, it's unbelievable. Only one of those 13 reasons is a reason good enough to ban them immediately, but to have 13. Now, the rise of the turbo cancers, the new cancers we're seeing in young people, you will see every day that when this is out there being discussed, the newspapers will say, oh, this is clearly due to diet or other environmental things. And the thing that really gets me in the newspapers that have comments from the readers online, they have these articles, and I always read the comments first, because the person would never even have mentioned vaccines. You go on everything but the vaccine. And the first comment will be, so nothing to do with the fact that this only occurred a couple of months after the vaccines were induced then. Why no comment on this when many... And then sometimes they mention me when I've been screaming about this is the cause of it for ages. Why didn't you mention this? And we all know there's been tremendous censorship from the government. I mean, I've been told by editors and producers alike that the government regards it as a crime to say or do or discuss anything that might make people lose confidence in the vaccines. Well, if a vaccine doesn't work and it's dangerous, I think it's a crime to prevent these things being discussed, particularly when the vaccines don't work at all. There is no benefit from them whatsoever. All the benefit was in the playstations of the statisticians who said we had to have them to save us. And every single thing, modelling that they've done, and I mentioned Neil Ferguson, as far as I can find, it's never been right. It's never been right because the modelling takes no account of real time. I mean, with the COVID, I mean, it was all exaggerated. The number of people who went down with it, were ill with it, or died with it. It wasn't anywhere near serious a thing. And I've written an article today in the Conservative Woman about what I call the vaccine wars. People saying we must have them versus the head of the NIH, Jay Bhattacharya, and Robert Kennedy. And others say, no, we must not be using these, particularly in young people, because they're aware that these things are highly dangerous. And what I was very pleased about, the Mail on Sunday did an article a few weeks ago where they let me and James Royal point out that these vaccines are causing the cancer. And we have seen it. I mean, they've been unbelievable. We're seeing cancers relapse that have been stable. We're seeing brand new cancers present stage 4 in people fit and healthy. And I did a big survey on this where I've seen dozens of patients. And the thing that strikes me was I was the only doctor with a GP, with a surgeon, with the oncologist, with everybody else who asked the question and said, can you tell me your vaccine history? Not one doctor had done it. And then those doctors will say, no, there's no association with the vaccine whatsoever. I see no ships. Where's the sand? I mean, it's unbelievable. And I've got no doubt at all these vaccines are causing cancer. And the more you have, the greater your risk will rise exponentially. And, the simple thing in that is that a booster vaccine suppresses your T cell response. Well, that's the only response that's going to control your cancer. So then it gets worse. And when I was asked about the fact, did I really believe this? And James Royal said we saw it. They have to balance it. Quite right. Very good. And so they got the experts and vaccines immunology from the places Imperial and things like that. And they all say something which is extremely correct. But the specious nature of their argument and the sophistry is it would be funny if it wasn't so serious. They all say messenger RNA is very, very safe. We get exposed to tons of it every day and it's all disposed of and causes no harm whatsoever. That fact is completely true. What they don't mention is it's so easily disposed with that in order for it to be a vaccine, we have to stabilize it so it doesn't get disposed of. Therein lies the problem. That the stabilization, these messenger RNA has been around. I was on a messenger RNA vaccine company board over 12 years ago. And they still haven't had anything approved. So now you know where you're coming from. So the messenger RNA, in order to deliver it, is delivered in such a way it can easily end up integrating. And then it hacks your genetic code. So they can then promote an oncogene, downregulate suppressor genes. I mean, the list goes on. It's horrendous. I mean, if you just see the one slide I had prepared for me of everything in the literature, by the time you get to the third thing, there should be stop out there, get rid of it. The whole thing should be put in the can. And the big problem is that there's a big industrial complex wants to make messenger RNA the big core of everything. And we fell for it in the UK. Sunak signed up to Moderna to make vaccines. I didn't see that ever go to tender, by the way. And I find it was identical in Australia. The same thing, they wanted $1 billion over 10 years. That you pay the money. It's like everything goes around. The government pays the money, you get nothing back for it. It's absolutely outrageous. We have to kill this culture and actually increase the health of the population. So that's where we are.
Well, Professor Dalgleish, I really appreciate you coming on. And you were, I think, really the only voice from a medical point of view, actually, who was able to be in mainstream newspapers, in your regular articles in the Daily Mail. There was a lot happening online discussion, but you actually breaking through in terms of the print media and putting it out. I think you were fairly unique. And
A lot of them will let me talk on all sorts of things. As soon as I mention the bad things of vaccines, uh, I started to put things into the print, and there would be the press, and it wouldn't get published. And
yeah,
I'd say, "What's going on here?" And they said, I mean, it was approved. I was told it would be out. The senior editor sees it and pulls it. And he pulls it because it says something negative about the vaccine. So he's worried about, you play ball with us and you get your knighthood type of thing for
yeah,
telling these lies to the people, and you'll be rewarded. That is outrageous. I mean, I only appreciated this when I did an interview on Sky News Australia, which is a really big thing.
yes,
And the producer basically said, I've heard you speak this, that, and the other. I want you to tell everybody about your experiences. And he said, I've been told not to let you talk about this, but he said, I've lost so many of my friends to vaccine damage and things. He said, I don't care. He said, I have a duty to get it out there. And so many people in the media have not had that moral fiber. That even though I know them very, very well, they won't let me tell the truth. But the other thing I find out is I'm finding it very difficult now to find anybody who doesn't know somebody or themselves who hasn't been damaged by the vaccine. And the most interesting thing of the lot is that they, even senior consultant colleagues of mine, haven't put it together that what they're suffering from only came on as a result of the vaccine. And a big issue is the vaccine causes this autoimmune disease. And autoimmunity, there's 131 different types, all of which have been reported in as vaccine issues. But when you dilute a big number by 131, you can just say, oh, it's all a coincidence all over the place. If you add it all up, it's an incredibly high percentage of people with the vaccine have suffered one or more of those 131 known autoimmune conditions, diseases. And the cost of treating those, is adds to the bill unbelievably. And the thing that's really annoys me, my own GP practice constantly bullies me for a new booster on this or a new vaccine on that, even though they know my views. Why do they do it? They get paid.
yeah.
But they get paid to do their job properly without the vaccines. And if they did the job first, do no harm, they would say, I'm not having anything to do with this.
Well, I'm sure that many of those articles you wrote have had an impact on the public and got through to them in a way that maybe social media couldn't. So, Professor Dalgleish, thank you so much for your time and for really going through your background and the developments you've seen and where we are today, and giving some of those kind of practical tips to people who may have got the news that they have the big C. So, thank you for your time today.
Okay, fine. Thank you very much for having me.